So welcome again. Thank you so much for joining. I'm Barbara McLean. I'm a critical care clinical specialist, and today I'm going to talk about forcing us to watch our fluids. Now, one of the most fantastic things about challenges and disasters is they really do help us to change our methodology and perhaps prove our style of management for our patients. So that's what my hope is going to be in this forced withdrawal of aggressive fluid resuscitation because of Hurricane Helene. Now, in order for me to do that, I always think it's important to start off with just very basic discussion about fluid and reminding us that when we talk about total body water, the largest amount of water is intracellular. And in the extracellular, so either inside the cell or outside the cell, the extracellular is actually put into two categories: fluid in the interstitium, which is the second largest amount of fluid, and the fluid that is in the plasma. Now, we typically refer to this as intravascular. So intracellular, extracellular divides to interstitial and intravascular, and that's really correlated to the plasma. But what I really want us to always remember, very important when we're talking about fluids and we're talking about fluid management, we're talking about our patients, is to remind ourselves that we talk about venous fluid and we talk about arterial volume. So that's a really important concept. I say it a lot. I'm never sure if people really appreciate, let me say it this way. I'm never sure if I'm saying it in a way that really drives home the appreciation of that issue, which is volume in the vein is not transporting oxygen or delivering oxygen to the tissue. Volume in the artery is. So our focus is really about how do we evaluate volume in the artery. Okay, so when we think about that fluid being divided between these two compartments, intracellular, the massive fluid, extracellular, the less massive fluid, comprised both of interstitial and plasma, 2/3 of your total body water is in the cells. So you're very abundant at the cellular level in terms of fluid. Only 1/3 is found in ECF, and actually almost all of the ECF, so 3/4 of the ECF, is found in the interstitium. However, you and I both know that what significantly impacts our patients is when there's fluid leak, and that fluid leak occurs because of the lining between the vessel and the interstitium, that would be the glycocalyx or the endothelium, actually has high degrees of hydrostatic stress because we're giving fluid. We're stressing the glycocalyx or that vascular separation wall, and the fluid leaks into the interstitium. So the interstitium gets larger and larger and larger. So now my interstitium may have 5/8 of the extracellular fluid, and I may only have 1/8 of my fluid in my vasculature. So this is a really important perspective. When we think about fluid resuscitation, how we're going to resuscitate patients, how we're going to withhold fluid in this upcoming crisis, want to remind ourselves that the human body overall compensates for mild to moderate hypovolemia, but cannot in any way compensate for hypervolemia. So just having said that statement, thinking about your generalized practice, what you do at the bedside, critical patients getting volume, even though I know you're limiting your volume resuscitation much more than you used to, we still are aggressively volume resuscitating patients at the bedside, and perhaps not even aggressively resuscitating them, just not really paying attention to all the fluid that they're receiving while they're under our care. That's coming to an end, my friends. This is going to be not possible. In the next few months, it will no longer be possible for you to have the luxury of volume resuscitating patients without directed desire. That sounds really good. I like the way that sounds. Okay, so if we just look at a 70-kilogram man, we just say, okay, total volume, 60% of his body weight, 60% of his body weight is fluid. okay? 28 liters in intracell, 14 in the extracell. Only 3 liters of that are in both the arterial and venous compartment. So that's a really small amount of fluid. So think about when you're giving somebody 3, 4, 5, 6 liters of fluid. Why? Normally there's only 3 liters. So why are we getting 6 liters of fluid? And where is that fluid going to go? Because it doesn't stay in the intravasculature. It stresses the lining, the glycocalus, and pushes the fluid into the interstitium, into the extravascular space. So typically when you're doing a fluid resuscitation, your desire, of course, is to resuscitate the vasculature because that's what you're trying to do. But as we do that, that supports that fluid leakage into the extravascular space and most particularly into the interstitium. Some of that fluid will actually move into the cell, but the cell, by the way, is already full, so it doesn't take that much fluid. So I really want us to really look at this because everybody probably knows all this information. But when we are thinking about giving 2 liters, 2.5 liters, 3 liters of fluid, and typically we're doing that to resuscitate blood pressure, it's important to appreciate that you have already replaced the vascular fluid total when you've given 3 liters of fluid. And your patient isn't necessarily getting better. In fact, he most likely is going to be getting worse. Maybe not worse right in that moment, but worse over time. So I always remind you to think about where that fluid is. When you're giving fluid into the veins, and of course that is where you're giving it, you're giving fluid into the veins, that crosses that capillary membrane as the hydrostatic pressure in the veins goes up. It crosses that capillary membrane and ultimately resides in the interstitium. So I start with the veins, I expand the fluid in the vein, it crosses the capillary membrane, and it ends up in the interstitium. Very little of it is actually in the artery. Very little of it gets into the artery. So this is quite important because from my point of view, I feel like in the last 10 years, my discussions about acute right heart failure, utilization of PEEP, nosocomial right heart failure, you're on 10 of PEEP, you got to be on Flow-Land, you got to do this. I can see in my own hospital that practice has really started to change, not just because of me, but a lot of people. But also, I really would like for us to be thinking about when we are actually aggressively resuscitating the venous compartment, because that's where we're giving the fluid, that what we actually tend to see is that as the vascular space gets larger and the interstitial fluid gets worse, so that's in your abdomen, that's in your lung field, that's in your brain, that's in all of your tissues, you actually, on top of the fact that you are not actually resuscitating the arteries, that interstitial volume load will start to compress the arterial bed. So now we're not only not filling the arteries, we're also compressing the arteries with that interstitial fluid load that's creating pressure, and then that pressure is being communicated to the arteries. So one of the things that I think is really important here, and I want to make sure nobody misunderstands me, I'm going to say it 15, 20, 30, 40, 50 times, probably 2 million times in my remaining career, and I probably already said it 20 million times in my prior career. Central venous pressure is an incredibly valuable component for you at the bedside to help you understand fluid resuscitation, not because central venous pressure is a volume number. Central venous pressure, when it's increasing, is giving you a reflection of the loss of right ventricular compliance. When we volume overload our patient, we have volume overload in the pulmonary bed, we add PEEP, we do these other things, it really puts your right ventricle at risk and your CVP will start to go up. So I believe vital importance here. You are bedside nurses in critical care. Your physician places a central line, you monitor that. They didn't ask you, they didn't need to ask you. Your policy in your unit says that you do invasive hemodynamic monitoring. You connect to a pressure transducer, any line that can offer information. And then from there, you take the steps to educate or re-educate your providers that CVP, as it goes up, does not necessarily mean I have more total volume. What it means is that I have engorgement of volume in my venous space. And the reason you care about this, my friends, is venous congestion is going to make organs more and more dysfunctional, in particular, the kidney. Okay. Now, the other thing we talk about is MAP, but in this situation, your CVP is going up. And yes, you do have a high volume load in your vein. It's not moving through the heart. It's not moving to the artery. So the MAP goes down. CVP goes up, MAP goes down. And this is a very common problem for us at the bedside. So we hook up a CVP, we hook up an AA line, we're monitoring arterial pressure, we're driving all our therapy towards the MAP. Meanwhile, the CVP is going up and the patient is actually getting worse and worse and worse. So we've really got to pay attention to this because we want to build a platform where we're understanding what we should be doing in terms of relationships of fluids for our patients. So I want to remind you some simple things when we're talking about fluid. Okay, fluid balance. When we talk about fluid balance, daily fluid balance is the sum of all intake and all output. And the cumulative fluid balance is the sum total of the positive fluids. So on the intake side, it's positive in relationship to the output side. Okay, so cumulative fluid balance, sum total of fluid accumulation over a set period of time. So one of the things I talk a lot about when I talk about renal replacement therapy is from the minute you put a patient on CRRT, you need to remove their basic carrier fluids. Carrier fluids are the fluids you're giving the patient that are carrying medications. It might be a KVO drip. It could be your norepinephrine, your epinephrine, your fentanyl, your propofol, your aminoglycosides, any other medications you're giving the patient. You're giving them fluids every single hour, and those fluids are not, they're just delivery fluids. They're delivering the medications. You have to remove those. You have to remove those. So if you are lucky enough to have CRRT on these kinds of patients, you must remove those fluids. Oh no, you say, my patient's blood pressure dropped. This little spit and spat of fluid every single hour, 200, 300, 400, 100, that little spit and spat of fluid, that is not resuscitating your patient. Stop letting your providers say, don't pull fluid, let him resuscitate from his hourly fluids. Nope, I'm going to resuscitate you with a fluid challenge, a fluid bolus, packed cells, albumin, but I'm going to pull off that hourly fluid. If I don't do that, my patient's going to get significantly worse because even in the most innocuous scenario, our patients exhibit significant profound fluid overload. So when we talk about fluid overload, we take the cumulative fluid balance in liters and we divide that by the patient's baseline body weight, multiply it by 100, and that defines the percent of fluid accumulation. Now that's really important because if your patient is 10% fluid overloaded, this is going to be associated with a significant poor outcome. And we have to pay attention to this. We have been for years cavalier about fluid resuscitation. So when we talk about fluid overload, a lot of it depends on what resources you're using, what you're using to calculate. But I want you to make sure that we have a basic calculation that correlates to a 10% weight increase from the patient's body weight is fluid overload. Okay, we should not be allowing 15, 20, 25, 30% increase in admission body weight. That is all fluid overload. 1 liter of crystalloid typically equals 1 kilogram of body weight. Now, our responsibility every single darn day, and you know what? I'm sorry, because I feel like every time we're together, I say, you've got to do this, you've got to do this. But you do have to do this. You have to be able to say in rounds, my patient has a cumulative fluid positive of 3.5 liters. You know why? Because If that patient's still making urine when you have a 3.5 liter fluid positive, your patient needs to get a Lasix test. And that actually tests to see if the kidney can regulate that fluid. And if your patient cannot regulate that fluid and he can't release that fluid, CRT is something you're going to want to introduce sooner rather than later, because we've really got to pay attention to that fluid load when we're looking at the patients. And by the way, when we start to look at the chest X-ray, we're going to see that really the very first stop in fluid overload, a lot of times in the patient when we very first see them, first stop is in the lungs, the very significant accumulation, the lung interstitium, which also starts to collapse the alveoli and fill the alveoli. And the second step is the kidney. So first stop of fluid overload, the lung, second stop in fluid overload, very typically is the kidney. So we want to be really attentive. And the first thing you want to do, so we're not even talking about looking at stroke volume, passive leg raise, CVP, MAP, every day, your commitment to looking at your I's and O's and looking at what increase in fluid the patient has. That is an incredibly important vital sign. And by the way, it depends on you accurately correlating and charting your patient's I&Os. And you can't go 2, 4, 6 hours without charting this, because we won't know what's occurring. And this is going to be a really important concept for us. Okay, so we understand a lot about fluid overload. I mean, I think in the last 10 years, there's been so much data about increasing mortality and morbidity when fluid overload occurs, but it still does, not with anyone's intention. Okay, so if somebody's acutely unstable, given a couple of boluses, a challenge of 500, another one of 500, another one of a liter, remember you only have 3 liters in your plasma. So that means venous plus arterial is 3 liters. So very important to remember that you don't want to overly aggressively resuscitate individuals with fluid. So first initial resuscitation, that would Manu Malbrain presented the Rose criteria, and that R stands for resuscitation. So we're going to resuscitate, typically going to resuscitate with about 30 mLs per kg. And that's okay in the hemodynamically unstable patient the first time they're hemodynamically unstable. But we really run into problems when we talk about the fluid that we don't account for or intentionally administer. Now, that's exactly what I was talking about with CRT. Your maintenance IV fluids, all the hidden fluids, all the medications that you're giving that are being delivered by fluids, all your flushes. Sometimes you're doing 4, 10, 15, 20 flushes. Those are 10 cc's each. Anything that's associated with any kind of continuous infusion or any IV piggyback. This is what I would say, this is inconsequential fluid. It's inconsequential because you're not giving it to resuscitate a patient, but you are actually causing volume overload. So in some studies, some of the recent studies say up to 60% of the patient's total fluid balance is unintentional fluid overload. Unintentional fluid overload. Okay, now, many people, myself, many other people have been talking about volume overload for quite a while, talking about the effects of volume overload, all of the organ dysfunctions that occur with volume overload. And we also have to remember that there are going to be some types of patients that actually need volume, like a person in the very early state who has an acute blood loss or body fluid loss. No, there's no therapeutic dilemma here. We're going to give you fluid. Patients who have high suspicion of septic shock, usually they get early goal-directed therapy, volume resuscitation mandatory in the first 6 hours, some small mortality benefit. It's not a great mortality benefit. That's why a lot of people are stepping back on early goal-directed therapy and volume resuscitation. But then we talk about the patient in the ICU who's already been resuscitated over several hours or several days, who is still getting a significant amount of fluid. Well, those days, my friend, these days are going to be over starting probably in the next 2 weeks. We are going to have to learn how to be fluid stewards. We're going to have to be really careful about the amount of fluid we're giving. So this was one of the first really, really important studies that said positive fluid balance and an elevated CVP. So fluid balance is up, CVP is up because you've overwhelmed the right heart, was significantly impactful in terms of mortality and morbidity. And that a more positive fluid balance early in resuscitation and then evaluated at around 4 days was a significant increase in mortality. So this is a really important perspective when we are considering what's important to our patients, how we're using fluids. So we can very easily say and very easily understand when we are fluid overloaded, we cause cerebral edema, and we might not be looking at that because we might not be monitoring ICP, but we can't wake the patient up, or we do wake the patient up and he's delirious. So he's got this intracranial pressure elevation, intracranial hypertension. As that's evolving, the compression of the cerebral arteries increases. And so compression of the cerebral arteries reduces the cerebral perfusion. So sometimes we see that in these patients early on, that they start to become quite angry. They're very delirious. Most of the time, we're not saying we need to look at what's occurring in the brain. Sometimes you take them for a CT, maybe you won't. We're definitely not sticking catheters in and looking at their intracranial hypertension. But what we really want to recognize is that if you've got peripheral extremity edema, you've got abdominal edema, you've got wet-looking lungs, you've got cerebral edema under our care because of our fluids resuscitation. This one is pretty easy. We look at this one all the time, right? We're looking at your chest x-ray. We see edema, we see ground glass, we see diffuse infiltrates everywhere. You have pleural effusion. Your chest wall elastance now has actually changed, and you have a high degree of lung water. And that water is actually going to compress your alveoli. And that means that you're going to have less ability to oxygenate your patient, that the lung volumes are going to go down. And what that leads to, my friends, is a prolonged ventilation, and can, of course, significantly and profoundly affect mortality and morbidity. For your cardiovascular system, it's going to significantly increase myocardial edema itself, can promote a pericardial effusion because of abnormalities in the electrolytes that may occur, could cause a conduction disturbance. Actually, we see lots of compression of the left heart and dilation of the right heart. So the CVP goes up. The right heart dilates, but it's really stiff and full. And as the right heart pressure goes up, venous return goes down. So your venous return going down means that you get really significant venous congestion, and that, of course, will lead to acute kidney injury and intra-abdominal hypertension. Oh, my Lord, have mercy. All of this from our fluid resuscitation. The other aspect, of course, is that fluid will accumulate in the gut and promote very significant gut edema that will form fluid, which we would, of course, call ascites, in the interstitial space in the abdomen. That's going to further compact and compress the abdomen, compress the arteries, going to your mesenteric bed and your and to your intestines, as well as to your kidney, your liver, and your spleen. So hepatic splenic flow goes down, renal flow goes down. And the worst part here is that because of that gut edema, now remember, we're going to have a kind of opening in the lining of the wall. Bacteria is going to start to translocate and move into the abdomen out of the intestine. And once that happens, the patient actually evolves a significant, profound sepsis. Okay, so last but not least, my friends, as you might know, I'm in love with the kidney right now. I'm in love with many things in terms of the human body, but right now, really in love with the kidney. And I want to remind you that fluid overload will lead to significant AKI. That contributes to hypoxia, mechanical ventilation. Mechanical ventilation contributes to AKI. This is a very, very intimate dysfunctional relationship. And it's going to be incredibly important when we're evaluating our patients. So we know kidney issues with volume overload with really aggressive fluid resuscitation, it may increase overall renal blood flow, but it may cause very significant disruption in the smaller vessels, the microvessels in the kidney, promoting a loss of the endothelial wall and translocating that volume out of the vessel. And that positive fluid balance very significantly deteriorates the cell oxygenation. So again, I want to remind you, you have in your hands a CVP and an MAP. If your doc put in a central line, don't ask if you can monitor it. Don't say, do you want me to monitor it? Monitor it. Offer the data. They may say, oh, CVP doesn't tell you about volume. Oh, thank you so much. I know that. CVP tells me about loss of compliance in the right heart and volume engorgement in the vein. And when volume engorges the vein, so goes the kidney, so goes all the organs in the abdomen. And eventually what you're going to see is an evolution of dysfunction. So I really do love the kidney, and it is really important, very significantly. When that CVP goes up, you have interstitial edema that increases the renal venous pressure, reduces the renal blood flow, causes a very significant dysfunction of the glomerular tubular interface, and then evolves our patient into acute renal failure. So I just wanted to show you, this is the increased venous pressure, which actually then engorges the interstitium of the kidney, increasing vascular resistance, but raising that edematous fluid, raising the interstitial pressure, and then ultimately destroying what we call the brush border of the kidney, that's in the tubules. The very thing you thought was helping your kidney, which was fluid, is actually going to destroy it. So just taking a quick look at this, you can see you have a patient who has a pretty good blood pressure, 98/44, MAP of 60, CVP is 19. For me, one of the most important things here is that I always say MAP minus CVP. That should always be greater than 55. Otherwise, you don't have adequate perfusion. So I'm going to try to get that CVP down. And one of the ways I'm going to try to get the CVP down is to be sure that I'm perfusing the pulmonary vault effectively, but I'm also going to initiate a Lasix test. I want to give the patient a Lasix test to see if I can waste some water. If I waste some water, that will decompress the right heart, that will decompress the pulmonary bed, and that may actually allow the CVP to come down as a secondary benefit. Also, really, really important when we're looking at those chest x-rays, we should be looking at the chest x-ray when it's been shot. It doesn't matter if you're not an expert. You can certainly remember that if you're shooting through air, it's going to be dark. And if you're shooting through fluid, it's not going to be dark. This is a very wet looking lung. This patient has failed the Lasix test. He failed the Lasix Bumix test. He's on norepinephrine of 70, epinephrine of 10. He's on vasopressin. His MAP is 60. He's the patient we saw before. MAP is 60, CVP is 19. So basically 60 minus 19 is 41. You need that to be above 55 if you want to have good perfusion. He's got an evolving base deficit. He's not doing well at all. Okay, here's the thing. As that storm swept through Western North Carolina last month, it destroyed the North Cove production site for Baxter, who manages and manufactures IV fluids. Dialysis solutions are not manufactured at the North Cove production site. So it's only IV fluids that have been profoundly affected by the loss of that site. They produce 1.5 million bags of IV fluid per day. Now let's think about that. We've already had 4 weeks. We've had a month since that destruction. Okay, so 7 times 1.5 is 10 million times 4. We have a loss of 40 million IV bags since the destruction of the North Cove production site. Now they're trying to move to other areas, negotiate with others, trying to increase in-demand production for IV fluids, but my friends, we are all going to suffer a supply chain shortage related to these hurricanes, okay? FDA has said, okay, we are asking hospitals to already ration supplies. We are asking hospitals to postpone elective surgeries. We are asking providers to actually do what they should have always been doing, which is reducing aggressive fluid resuscitation when it's not appropriate. And that comes to us. We have to actually understand and really organize strategies about how we're going to give patients fluids. No more KVO. Very significant limitation of flushing. Small bags for your pressure monitoring. No liter bags for pressure monitoring, only a 500 cc bag for pressure monitoring. Don't hang a liter bag. We need those bags. We can't use them for simple pressure monitoring because you can do that with a 500 cc bag. So on this past Saturday, right, just 4 days ago, CDC said these shortages are going to be significant. They are going to impact our patient care, and they are going to require adjustments to clinical management of patients. My friends, get ahead of the curve. Get ahead of the curve. Actually determine what it means to be fluid responsive. Fluid responsive means that your patient has a significant improvement after a small amount of fluid is given. Okay, you want to know if a patient is fluid responsive. You can give a patient 250 cc's of fluid in 5 minutes. If their stroke volume improves, if their MAP improves, if their glomerular filtration rate improves, and if their base deficit goes down. But the easiest one is stroke volume. That means you're monitoring stroke volume. Stop talking about SVV. I was in the burn unit the other day and I'm talking about stroke volume, and someone said, well, our doctors we never use a flow track because they said it doesn't help patients because we can't tell when their stroke volume is not reliable. No, stroke volume is always reliable. Stroke volume variation is not reliable. Stroke volume is reliable. If I give you a 250 cc bolus in less than 5 minutes of fluid, your stroke volume should increase 10%. Now, that's not very much. If your stroke volume was 40, that means it's increased to 44. But I'm going to then give you another 250 cc because you need that volume. If you need that volume, you should get that. You could also not give volume and just assuring that you are doing a passive leg raise correctly, and you need to be sure that you're doing it correctly. It's not just lifting up the legs. You could do a passive leg raise and let the patient resuscitate himself. That will tell you if the patient needs volume. Okay, so before you give volume to a patient, know that they need volume. That's the most important thing. If I give you volume, your stroke volume should go up. If I give you volume, your MAP should go up. If I give you volume, your CVP should not go up. If I give you volume, your glomerular filtration rate should improve, and ultimately you should wash out your base deficit. I am the nurse giving you volume. I am not giving you volume because you're hypotensive. I need to give you volume because you're fluid responsive. And this shortage of volume should be guiding us to doing a much more effective and better job. Whoop. Okay, so when do you start fluids? Right? You start fluids when somebody is empty, and you have to actually be sure that they can respond. And you're going to stop fluids when they no longer respond appropriately. And then you have to start fluid removal. Okay, so of course, fluid removal is urine. Basically, you're going to stop when they're about half empty or when they're about half full. And so how we're going to do this, we're going to use the tools that we talk about every single day. You need to resurrect those tools. You need to remember that your focus is stroke volume. Stroke volume as it responds to fluids. If your patient's stroke volume doesn't respond to fluid, fluid is not the right answer for that patient. Very important to us when we think about our folks. Okay. So basically, we talk about the 4 things that we do with fluid is when do you start, when do you stop, when do you start fluid removal, and when do you stop fluid removal. And these are really very important aspects in terms of fluid resuscitation. But for me today, what I want to say is you have to have communication with your team. What is the target for my fluid resuscitation? And that target really can't be MAP. It has to be bigger than that. You've got to have more information, stroke volume, base deficit, GFR. MAP is okay, but you got to have other aspects. You're not just going to flood patients chasing MAP because, my friends, this is from the work of Manu Malbrain, probably the most well-known surgeon in the world who talks all over about fluid resuscitation. I've been very fortunate only once because I can't really afford to go to too many meetings. This is the International Fluid Academy. It's in the Netherlands every year. And this is his slide. He said, okay, remember that patients who are septic are vasoplegic. They are not hypovolemic. Don't just hang your hat on volume resuscitation. If your patient is vasoplegic, and typically vasoplegia is expressed by the diastolic blood pressure. Diastolic pressure affects the mean. If your patient is vasoplegic, they need a vasopressor, a gentle vasopressor, not starting at 2 and then going to 20, a gentle vasopressor just to give them vascular tone so that as you give them fluid, they will have an appropriate response. It's really important to appreciate the balancing act that we apply every single day. So I think when we talk about patients in the ICU who've already been resuscitated, they've been resuscitated on day 1, probably on day 2. Now you're with them on day 3. They're unstable. They require therapy, but if they have a cumulative fluid balance greater than 10%, you cannot give any more fluid. And they are typically no longer fluid responsive. You want to remember, once they have a cumulative fluid balance of 10%, the risk for pulmonary edema is profoundly high, intra-abdominal hypertension is high, AKI and ARDS all high. So that person who came to you to get better gets worse because we are indiscriminate in fluid resuscitation. Now, we're not going to be able to act that way now because we're going to have to be restrictive on our fluids. So let's start that before it's mandated. I want to remind you, really, really importantly, the CVP is affected by the venous return. It's affected by the capillary filling pressure. It's affected by the volume that is what we call the stress volume. That's the volume that gets returned to the heart in physiologic stress. But the biggest factor that affects your CVP is the integrity of the cardiac pump. So I do want to remind you that when you start seeing CVPs going up and up and up, and blood pressure going down and down and down, and the patient becoming more and more hypoxic, this is a time to actually say, we need to take a look at the right heart. Perhaps we need to look at pulmonary vasodilation. And I think in my hospital, even the last year, because I know I talk about this all the time, and I talk about it with providers, APPs, the nurses, we in my place are seeing much more pulmonary dilation in patients who are volume overload and who have right heart dysfunction. So I think that's a really important strategy as we move forward and we try to do the right thing for our patients. So for us at the bedside, we really want to have what's known as the 5 R's in fluid resuscitation, right? Does this patient really need fluid? Does he really need enteral fluid, or does he need IV fluid? Does he need maintenance IV fluid versus bolus IV fluid, right? Maintenance IV fluid is all the fluid that you're giving the patient every hour. Their KVO, their carriers of fentanyl, propofol, epi, norepi, aminoglycosides, whatever medications you're giving, those are maintenance fluids. But if they're hemodynamically unstable, they need a bolus fluid. And you need to make a decision on bolus fluid. Do you want to use crystalloids or colloids? For me, it would be crystalloid. If I'm going to give you a colloid, it's going to be 25% albumin. I'm not wasting my time with 5% albumin. Got to use a volume responsive tool to see if patient continues to need IV fluid. So stroke volume, POCUS, passive leg raise, you choose. Happy to discuss those all. I've talked about them a lot. Happy to talk about them again. You choose what you can do with the resources you have at your institution and what you're comfortable with, but to give fluid without actually evaluating whether the patient needs it or not is going to be passé. You're not going to be able to do that anymore because we're really in a fluid restrictive state. Okay, so then we just think about what kinds of fluids we're going to give. Can we concentrate more so we can reduce hidden fluids? And you need to be prepared that everything we're going to be doing is going to be hyper concentrated now, just in order to reduce the utilization of fluids. And please don't waste fluids. So we're really going to see like straight sodium bicarb infusion rather than 150 milliequivalents, and on and on and on. Anybody who can get PO should get PO, so that we minimize, first of all, hidden fluids, and also so we're reducing the demand on a shortage of IV fluids. And then really, really important, when you actually are looking at a patient who has interstitial edema, 5% albumin is not going to mobilize that, but 25% albumin can help mobilize the interstitial fluid of the patient. Typically, that has to be followed by Lasix. So 25% albumin, 20 minutes later, 40 of Lasix. That actually allows the patient to mobilize his own fluid and restore himself. So really important for us to think about these strategies of what we'd like to do in this new time where we have lost our IV fluid abundance, where we're going to be a little bit impoverished with IV fluids. So I think it's always really important to direct your fluid goal. Always remember, if your patient is significantly hemodynamically unstable, you're not sure really what's going on, we're going to give about 30 mLs per kilogram total within that first 6 to 8 hours, not 30 mLs per kilogram over 6 to 8 hours. That's what they're going to get total over that period. And then we're going to actually follow that typically with a negative fluid balance. And that's because if we continue on this path of giving fluid, first, we're going to empty our stores. And second, it wasn't, and it hasn't been, isn't now, and will not be the appropriate therapeutic approach to patients. Patients who need fluid should get it. But just because you have a patient who's unstable doesn't mean that fluid is the answer. And we have not done a good job at sequestering out patients who need fluid and patients who need something else like inotrope or vasopressors. Or maybe they need fluid, but it's 25% albumin, not crystalloids. And then we really have to think about, at the end of that first week, should we start removing fluid? An active removal of fluid means that we're doing aggressive diuretics, and we're going to actually consider renal replacement therapy, even if you're not in kidney failure, because we got to pull some fluids off. And of course, that's referred to as deresuscitation. So then I just want to remind you about fluids and what is best. So I know many of you have heard me talk about this before. So if I just take a look at what's in your own blood or plasma that's from the lab, sodium 140, chloride 103, potassium 4, calcium 5, mag 2, bicarb around 25, pH 7.4 with an osm of 290. Okay, so when I look at sodium chloride, you can see sodium is high, chloride is high, and when chloride is in a high percent in the blood, it binds to the metabolic acid hydrogen, and that actually can cause a significant acidosis. But it's an acidosis that gets missed. No potassium, no calcium, no mag, no bicarb, pH about 5.7. Lactated ringers, a little bit better, 130, 109, 4, 3, no mag. Buffers are a lactate. Lactate requiring liver function. Lactate is conjugated to bicarb, so it is a neutralizing or a buffering solution as long as you have a functional liver. And the pH of that is about 6.4. Okay, so look at sodium chloride, 5.7. Every liter you give, 5.7. Lactated ringers, every liter you give, 6.4. If you're using plasma light, you can see that it's very close to what's in the plasma. No calcium, but you got mag, you got potassium, low chloride, high sodium, acetate, which is also going to help us to neutralize metabolic acidosis, and a pH that's just about the exact range of pH for someone normal. So my friends, what I would tell you is if you're limiting fluid resuscitation, try to choose the fluid that's going to give your patient the best possible step forward in recovery. And in general, that's going to be plasma light or lactated ringers. I don't think very many of us use normal saline as a primary resuscitation fluid, and it's pretty darn, it's very helpful if that's all you've got, but it's quite egregious over time, and we really don't recommend using 0.9 normal saline. Now, I just want to remind you again that when we look at these ions, it's really important to look at where the pull occurs, right? So sodium is 140 in the interstitium and 140 in the intravasculature. But when you break that little barrier, that sodium and water is going to move very aggressively into the interstitium. So that's one of the reasons we don't really want to use sodium chloride solutions. Hypertonic saline is different, but just 0.9 normal saline, very problematic. Remember that potassium in the cell is at 150, interstitial, intervascular, very low level. Chloride in the cell is 10, interstitial, intervascular, relatively low level. Bicarb 10 in the cell, 25, 25. But here is what you really want to remember. Protein, albumin, much higher in the intravasculature. Blood cells, white cells, platelets, much higher in the intravascular. So one of the things to be thinking about, you walk into the room, it's 3 days that your patient's been in there. He's been getting a lot of fluid. He has ARDS, he's evolving AKI. His hands and feet have profound peripheral edema. Have some discussion about what we can do to actually try to pull fluid back into the vasculature. And we can do that not with 5% albumin. 5% albumin is basically a crystalloid, but we can do that with 25%. We can do it with blood. We're not going to give proteins. We're just going to give albumin and blood. That will actually help to mobilize that blood back from the interstitium back into the vascular bed and ultimately, hopefully, improve your patient's outcome. I think lots of docs now are talking about methodologies of fluid resusc, that they're going to use more FFP, they're going to use plasma, they're going to use blood, but then we're going to end up with a blood shortage, and we have to be sure that we have blood for our patients who have trauma and who have hemorrhagic shock. So I do think it is important to remember about crystalloids and colloids, that saving a life using crystalloids costs about $45, and saving a life using colloid is about $1,493. I don't care. If it's my patient that I'm worried about my patient. It is really, though, important just to remember that crystalloids are cheap and there's no allergies associated with it. You're not transfusing, you're not actually donating an organ, right? When you're using colloids, you are significantly putting patients at risk for transmission of infection, and you may be interfering with coagulation. So it's very, very important to remember that. Low volumes needed here when you're giving colloids, but you do have some secondary disadvantages that can be problematic for our patient. Now we're going to take a quick look at this patient just as an overview. It's a 42-year-old man with hypertension who had exploratory lap, and he had perforated peritoneum and peritonitis. Kept NPO, prescribed IV 5% dextrose, 0.9 normal saline, 5% dextrose, normal saline at 150 an hour by the surgical trainee. By day 4, so he was getting First, he got IV dextrose, then he got 0.9 normal saline, and then he got D5 normal saline at 150 an hour. On day 4, patient's serum sodium is 153. No surprise, he was getting serum, he was getting sodium. Potassium 3.1, chloride 123, and creatinine 3.8. Gets an arterial blood gas. He has metabolic acidosis, he has a base deficit and a low bicarb. But something that we use to actually help us understand metabolic acidosis is the anion gap. And the anion gap is 12 plus or minus 2. Well, his gap is 9, but he has pretty significant metabolic acidosis. Now, this is a big issue here because this patient was receiving the wrong IV fluids. He was receiving the wrong IV fluids. And now he's got a serum sodium of 153 and a chloride of 123, which now has caused a metabolic acidosis. That is called a non-GAP or hyperchloremic acidosis. And that frequently will happen when we're using aggressive sodium chloride solution. So this is one patient where, again, we're not paying attention to the things that we're doing in terms of the way that we're resuscitating. So I want to make sure we have good take-home messages. Fluid overload is defined by a cut-off value of 10%. Okay, that's just an increase in body weight. You have to weigh patients every day. You have to do INOs every hour. You need to be communicating an increase in body weight, not just assuming that your team is looking at that. You need to communicate an increase in fluid, and you need to talk about an increase in body weight, because we should stop using fluids for those folks, making fluids more available for patients who are in crisis. Fluid overload is associated, 100% associated with an increased mortality and with organ dysfunction. And we must insist that we have a target, and not just one, but a platform of targets for resuscitation. Passive leg raise, POCUS, stroke volume, base deficit, GFR, as much as you can gather together, you would like to have a great target for resuscitation. This is an incredibly important component in today's world, not just because we have fluid shortages, but because we've always had the abundance of fluid, because we had fantastic work from Dr. Manny Rivers about early goal-directed therapy, and we very aggressively resuscitated patients. But now we have learned that it is not necessarily that the patient needs volume, it's that they need arterial volume. So I want to remind you, a balanced approach is fluid to a target that shows the patient's responsive, inotrope to improve blood flow dynamic, and vasopressor to improve vascular tone. As we move forward, I'm going to have lots of updates about fluids. I do want to share with you one piece of information that I got expressed to me yesterday, which I thought was fantastic. So the North Cove facility makes IV fluids, not dialysis fluids, and this is Baxter. So in my institution, we use only 2 types of dialysis fluids. That's the 2K solution, the 4K solution. And I understood a main hospital in our city has already taken steps to control fluids in the place where they're using it the most, and that would be in the OR. So in the OR, when they're doing aggressive resuscitation, they are using 5-liter bags of dialysate. And that dialysate would be the Foxilin, that's the 4K. 4K has sodium of 140, mag of 2, phosphorus of 1. It's actually very close in integrity of plasma light, but you cannot use that unless you are giving 5 liters of fluid. So it can only be used for massive transfusion because it's very expensive, and then we're going to end up having a run on dialysis fluids. So keep your ears peeled. I'll have some really great updates. Hopefully next week we can have another little talk. Might take a little more talk on what should you be doing to make sure your patient needs fluid, and if not, what should you do next? and I'll keep you updated on the status of fluids in the United States of America and around the world as we enter this whole new supply chain issue. And by the way, my friends, from this moment forward, try to conserve fluid, don't waste it, try to conserve it, and use 500cc bags in all of your pressure monitoring. Don't use those liter bags. We need them. All right, my friends, thank you for joining today and always. Many of you are here every time I have a talk. Sorry about yesterday. We had a lot going on and it was a hard day for us to do a recording, but I'm so happy to be with you today. And I'm going to see you next week, Tuesday and Wednesday. Thanks so much. Bye-bye. Thank you.